Welcome to the Future of Dermatology podcast. I'm Dr. Farah Kamangar. What you're about to hear is a standout session from this year's SF Derm Conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
So objectives today are really to talk about how an allergist looks at chronic urticaria mainly. We're going to talk a little bit about atopic dermatitis. As mentioned, I am an allergist at OHSU. I run the Multidisciplinary Clinic for Severe Eczema with Eric Simpson up there. And so that's my real connection with dermatology. But again, CSU, I think, is a great collaboration opportunity as well. I don't know if you guys... allergy season is still present here, but in Oregon, in the Willamette Valley, so our wine country up there, June is the worst allergy season. It's grass pollen season. We have the highest grass pollen counts in the world up there. And this month, we see more episodes of anaphylaxis associated with allergy shots or food immunotherapy than the rest of the entire year combined. So that's why there's no allergy conferences in June, ever. It's always off season. It's like February and November. That's when all the allergy conferences are. All right. So pull out your phone. I want you to take a quick picture of or pull up the QR code here. So you have an 18-year-old female who presents to your clinic with 2 years of CSU. It's poorly controlled despite utilizing high-dose second-generation antihistamines. What advanced therapy do you choose? There's going to be a bunch of questions, so start with this one. That's a pretty good number. So one thing that came up earlier when Jason was talking was which antihistamine to use. So did you guys see the new FDA warning about antihistamine use? Has any of your patients brought that up yet? So the FDA came out and said patients on long-term use of cetirizine or levocetirizine, when they come off, they may be at risk for severe pruritus. And so I've had so many patients come to me and be like, why didn't you tell me this? I still love cetirizine. It's cheap. It's very effective. Very great safety profile. And it's a very rare phenomenon. We've been seeing this for decades. This isn't new. We've seen this forever, that there's these select patients when they come off, they get really itchy. It's actually not that hard to deal with. You just put them on liquid cetirizine, taper them off 1 milligram per week, and they do just fine. It is not really a huge deal, but a lot of patients are bringing that up now. All right, let's see all right, omalizumab, dupi, methyl. Okay, sounds really reasonable. All right, I'm going to add a caveat here now. Same patient, but they have a known food allergy, egg allergy. Does that change what you end up doing? Scan the code again and answer the question, or it'll pop right back up on your phone if you kept that thing open. Let's get to 25. All right. Oh, we're choosing dupilumab now. Does anybody want to say why they chose dupilumab? Which of these biologics is approved for IgE-mediated food allergies? Omalizumab. Right? So you would think that if somebody has an IgE-mediated food allergy plus chronic urticaria, you would probably want to lean towards omalizumab versus dupilumab. Dupilumab didn't show efficacy in reducing severity or frequency of food-related IgE episodes. All right. Same patient again, but now you learn that the food allergy isn't IgE-mediated. It's actually EOE, Eosinophilic Esophagitis, 2-egg, in addition to the chronic urticaria. Now, does that change which medication you choose? All right, perfect. So absolutely, right? Dupilumab is approved for eosinophilic esophagitis, while omalizumab isn't. So it's not just do they have food allergies or not, what kind of food allergy do they have? in addition to their chronic urticaria, that may help you decide which biologic to choose. Up until now, we had one choice, right? After they failed high-dose antihistamines, they go to omalizumab. That's all we had. Now we're going to have many choices. We already have two now. Like Dr. Hawk said, we're going to have remibrutinib very soon, and there's a whole host of ones that are going to come out in the next couple of years. Knowing what they are useful for, their underlying mechanism, may help us decide which one is going to be best for our patients. It's also important to remember that CSU is really a systemic disease. We think about it as itch, we think about it as hives, we think about it as angioedema, but there are so many systemic manifestations that come with it. These include joint pain, joint swelling. This can be sleeping issues, pain, fatigue, wheezing. But some of these could be associated with just poor sleep because you're itchy all the time. But some of these seem pretty independent of that as well. But we do know that treating these patients with systemic therapies often improves these other complaints as well. And Dr. Hawks kind of mentioned this already. There's a lot of concomitant conditions that come with chronic urticaria. Really, I want to concentrate on the atopic conditions and autoimmune conditions. When we think of atopy, we think about this in atopic dermatitis all the time, right? Patients have eczema. Oh, they're going to have food allergies. They're going to have allergic rhinitis. They're going to have asthma. It's also true in these patients with CSU. Across the board, different countries, very, very similar findings that 20% of these CSU patients have asthma. 15 to 20% of these patients have allergic rhinitis. 8% have food allergies. It is important to understand that these patients are not chronic urticaria by itself. Really understanding what comorbidities or, I guess, concomitant conditions these patients also have is going to be important when how do we manage these patients? How do we tell these patients what to do next? Very, very, very important. In these young atopic dermatitis patients, right, we tell them, okay, especially if they have moderate to severe eczema, we know that increases their risk for food allergies. We know that increases their risk for asthma. There are predictive calculators that are very easy to use that you can just plug in when you see these patients and say, yeah, your risk for asthma is 95%. This kid's going to have asthma because they have severe eczema. They already have food allergies. These tools exist already that we can tell these patients what to expect going forward. In our multidisciplinary clinic, the way we have it structured is a little bit different than they do at UC San Diego or Rades, is the dermatologist goes and see these patients first. Then they come out, we chat about the patient briefly, I go see these patients afterwards. It's great when you have these patients that young kids, severe eczema, parents are super concerned about foods that are causing it. Dermatologist goes in, says, it's not foods that are causing this, let's work on the skin condition. I go in right after, exact same question. What food is it? I'm like, dermatologist just told you that it's not a food. They want to hear it from us. And I understand that. And I think allergists understand that if your patients are really like, we need an allergist to tell us the same thing that you guys just told us, that's fine. Refer them over to us. But the more times that they hear it from different providers, the better it is for them, the better it is they actually hear it, and the better chance that they actually go forward with the treatment plan. We don't necessarily test them for everything just because they want to be tested for it, because we know that false positive rates of food allergy testing, IgE testing, skin testing is extremely high. But just, again, hearing it from dermatology, hearing it from allergy, multiple people saying the same consistent message really makes a difference and prevents us from doing unnecessary testing.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.